Hi everyone, thanks for coming. We'll just do a quick round of introductions. My name's Josh. I work as a neurologist in the NHS, and more recently I've been involved in a lot of AI research and moved to industry, most recently working at Tortoise, building ambient voice technology for the NHS. I'll let Zeljko introduce himself as well.
Hey everyone, so I'm Zeljko. I'm an associate professor at UCL. I teach AI for health. I'm a CTO at a company where we do, again, AI for health, and all of my experience is basically just a developer or on the technical scientific side of bridge between AI and healthcare.
Yeah, we started this podcast because I was working as a doctor and I found it so hard to actually upskill myself. There was a lot of talk about AI workforce upskilling, and it's actually so hard when you're working full-time as a doctor, as a nurse, as a physiotherapist, speech and language therapist, whatever, to actually get those digital skills to be AI ready. And through conversations with myself and Zeljko when we were working on research together, building tech together, we realized that we wanted to share these conversations so we can help other people kind of understand this bridge between the clinical and the technical. Because what was happening was, as a doctor, I saw problems in the NHS that I wanted to fix, but I didn't necessarily have the technical or AI skills to solve it. Whereas on the developer side, they know the tech, but they don't know the real-world problems that are happening in the NHS. So this podcast was started in the hopes of having those conversations and, hopefully changing the workforce and upskilling people. So today we're going to talk about AI agents. There's been a lot of change in the past 2-3 years, right? From ChatGPT to reasoning models to multimodal and voice agents. And this last year we've seen so much growth in artificial intelligence. The biggest change is this idea of agents. So I'm going to pass over to Zeljko and maybe just talk about how would you define the agents? What is an AI agent even?
Yeah, as you can imagine, a lot of AI is hype, and basically the currently most hyped term is an AI agent. No matter where you look, it's like, oh, this is an AI agent, that is an AI agent, my bottle is an AI agent, my fridge is an AI agent. I don't think so. I think there is a decent definition of an AI agent, and that would really be an AI model like ChatGPT or Claude or Gemini that has access to a set of tools and can use those tools to iteratively solve a problem. So if I look at a very simple thing like, oh, I want to book my holidays in, I don't know, somewhere nice in Thailand, I can give that task to my agent and be like, find me a good date in March and the hotel and everything else. And then the agent will go off, check flight prices, go to Booking, find a hotel, go to Airbnb, find a good price, summarize all of that and then present me with a solution. That's an agent, something that can interact with the real world using a set of tools to accomplish a task. So currently the two most popular agents or two most popular use cases in AI in healthcare are AI scribes and something around mental health chatbots, like AI chatbots for health. Now, Josh, you have basically spent the last year in an AI scribe company. So what's your take on this? What's an AI scribe? What are the extra features? What is the good and bad sides of all of that?
Yeah, you might have heard a lot of talk about ambient voice technology, AI scribes in the NHS. It's been promised as the silver bullets, right? Even Wes Streeting, Keir Starmer are saying we need to automate administrative tasks in the NHS. And there is a lot of value in that. But, just stepping back, there's 150 different scribe companies at the moment, 150. And a lot of them are getting venture capital funding. So I worked in Tortoise, one of the London-based ones, for a year. And what I'm seeing is, for sure, 150 of these companies won't be around in a few years' time. And what everyone is trying to do now, it's a race to basically make these, we call it AI Scribe Plus features, right? Anyone nowadays can build an AI Scribe. You can vibe code an AI Scribe in 5 minutes. What's difficult is the implementation, the integration, but also the offerings that you give after. So there's a lot of talk about, clinical coding, medical billing, using AI scribes to help uncover insights into a hospital's population, epidemiological studies. So like one cool idea I had, which I never fully enacted, was if there is a wide uptake in AI scribes and you're processing and recording these conversations between doctors and patients, you have a pulse of the country, right? You know what consultations are taking place, and from there you can do all kinds of population health studies. You can even track pandemics. You know when it's flu season because everyone's at the GP talking about cough and cold and fevers. So I think, there's a big move to this AI Scribe Plus feature.
So given that there is 150 of these companies, how should a hospital decide what's a good AI scribe company? How do you evaluate? And I also have the question on the other side, because a lot of companies are complaining about hospitals. What hospital makes a good partner, and how do you decide that?
Yeah, I don't know if any of you were at the talk just before with Sonia, the CTO of NHS England. And there's always talk of AI readiness. There's a million frameworks. To be honest, what I've seen firsthand is there is increasing funding for AI scribes, but there is always such a battle to get technology uptake in the NHS. You have to go through so many meetings, procurement. I think that there needs to be a faster procedure to evaluate technology. And it's not just, is an AI scribe the right partner for the hospital? But what I saw was, is the hospital a right partner for the scribe? Because a lot of hospitals are asking for free pilots for bespoke features. And, as a startup, when you're running on limited funding, it's very difficult to build all those features and run free pilots. It really stifles innovation. So, one thing I really want to see is hospitals being more eager to uptake technology, having some kind of fund there to actually support pilots, and also evaluating the technology, right? This is very hard for trusts or GPs to actually evaluate, is this scribe actually working well for our departments? What does that even look like? There's not enough expertise on the other side to fully evaluate it.
No, yeah, I completely agree. And I think to switch gears just a little bit, I want to mention also the other most popular use case, which is the mental health chatbots. I have a love-hate relationship with those. It's sometimes think, oh, this is an awesome idea, and sometimes oh, this will cause AI psychosis or something we are seeing a bit recently in the news and everywhere else. So what's your take on that part?
Yeah, who here uses a large language model like ChatGPT, or who uses AI in their daily life? Okay, so only half. But you might have seen on the news, right? ChatGPT has been almost encouraging users to enable them to commit suicide, or a delusional person might use ChatGPT, and what we're seeing is these large language models can reinforce delusional beliefs in users and push kind of extremist viewpoints. We recently published a paper on this where we experimented with different models. We gave the model different scenarios where a patient with delusional beliefs or psychiatric disorders would speak with ChatGPT or similar models. And we found that every one of them had a propensity to reinforce delusions and cause more extremist beliefs, amplify biases. So this is a big worry of mine. And it ties in parallel with one of the biggest AI mental health chatbot companies called Wobot. They were doing really well. They published some big papers, got some funding. They recently shut down just because of these concerns and the barriers to regulation and getting that actually approved. So, yeah, there's a lot of hope, but there's a lot of drawbacks and worries that we need to tackle as well. But maybe just moving on to a different use case. So, we're talking about AI agents, and we've just covered the most common accessible use cases. The one upcoming one is called computer control. So basically automating mundane tasks with artificial intelligence agents. Zeljko's been working for the past year building some of this, so what's your thoughts?
Okay, so now we enter the area of science fiction. So basically, like, computer control is a bit of a holy grail of AI agents, because if you can get an agent to control the computer and do everything there, you almost can do anything. Like, it can read your mails, go there, browse something, code something, access the electronic health record, find patients. Like, no matter what you do, the moment you have computer control to a sufficiently high level, you enable an insane amount of use cases. Good and bad parts here. The bad parts are every company that has tried this has failed. So no, obviously it is a very hard use case.
Actually, Tortoise, the startup I was in, started off as a computer control startup and then pivoted to AI scribes, funnily enough.
Yeah, obviously a very hard thing to do. But what people are doing today, and what I've done in a London-based startup recently, was you find a specific use case. Like, you find a workflow you can automate. So one workflow can be like, oh, you check up on patients, are they lost in the health record system? Because that happens fairly often.
Ordering bloods as well, ordering big bloods. Consents.
Exactly. So you have an agent click around the EHR, try to find the patients and see, is everything being done on time, or should someone be reminded about something and send off a mail? Like, this is a very mundane use case. It doesn't harm anyone. There is very little harm, it's clicked something wrong in the record. It cannot remove anything. It can just like go through it, read, and notify people if something is delayed. So like, computer control is the pinnacle, but we are starting fairly low, and we are starting with automating workflows that exist either in hospitals, but also in almost any other industry. You find a repeatable task that consists of a couple of clicks or something in the HR, and you automate it with an AI agent, basically.
But what we found hard was like, the automation part can be tripped up by unexpected changes. So like, if an advert pops up or something, it doesn't know how to like click off the advert, or like if there's an alert in the EHR, like, are agents getting better? Are we at a point where this can happen?
Agents are getting better, but I also want to mention why do we need this use case? Is because, like, why do you need to click around an EHR instead of integrating with it directly? And this is because all EHRs are very difficult to integrate with. This is like another thing that I would love to see more in the NHS, is push all of these EHR systems or companies to enable integration. Like, not make it so hard to integrate that you have to spend 3 years to integrate with one of the EHR systems. That makes no sense. That's why people are going the route of, oh, if I cannot integrate, I'll make something that clicks around on the desktop, on my computer, the same way a nurse would click, or the same way a doctor would click. But I feel like that's a wrong solution to an easy to solve problem if these companies would collaborate.
Yeah, but there's conflicting interests, right? Like, Epic have their own AI scribe, so like, trying to integrate a scribe of Epic, they obviously are not going to make it easy for you.
Yeah, of course, but the NHS is in our service. It is not a private company, so they should push Epic and anyone else. But okay, we can like, do not go too much into that.
Just moving on to the kind of most future-facing kind of agentic use that we're seeing, and that actually we've been building in the last couple of months, is digital twins. I don't know who's heard of digital twins here, but it's a concept that was inspired by engineering, right? So if you build a bridge, you want to build it virtually first, see if the tensile strength is good, see if it can bear load, right? So the same concept is now being applied to healthcare. Can you make a digital twin of a person, right? And how do you do that? Like, it takes a hell of a lot of data. Zeljko's been one of the pioneers here. You've trained a model called Foresight in King's and UCL, trained on a couple of millions of patients to basically so if you imagine large language models like ChatGPT, they're trained to predict the next word, right? So you're saying the cat sat on a blank, and then you train the model to predict the next token, the next word that comes up. And now, instead of words, imagine you use a patient's diagnostic codes. So as I get older, I might have more conditions. I might have hypertension. I might develop diabetes. From the diabetes, maybe the next most likely thing is complications, diabetic retinopathy. So you train a time series model on predicting the next clinical events. And it's kind of wild how this even works. There's been a couple of big papers out. Epic have trained their own with some help from you with their data, as well as a recent publication in Nature. So if you imagine you train a model that can predict the next disease, you can actually look backwards to learn the natural progression of disease in humans. So it's quite a thing to wrap your arm around. But maybe, Zeljko, can you give us some insights into the model and what you think is the future with this?
Yeah, so, okay, I'll keep it very high level, but if someone wants the details of how to implement everything, ask later, just to not have everyone run away in the next 2 minutes. The primary idea of the digital twin is to move healthcare to be more proactive instead of reactive. Because if I can predict the future, if I can roll out the future for myself and see that in 5 years I'll have diabetes, I might work on preventing that diabetes, which is 1,000 times better than getting it in 5 years and then treating it for the rest of my life. So like that's the main idea with the digital twin, is how can we create a twin of you and then like imagine that twin is in a virtual world. We speed up the time for that twin and then we see what is happening. Like we see what is happening in the next year, 2 years, 5 years and so on. And that's the main idea. And that's also a company where Josh and I are working since a couple of months, is trying also to do that. On the other side, the purpose or the idea of the digital twin in my mind is really to have something of a distributed or decentralized health record. Like you have your health record, you have your digital twin with you. Wherever you go, your health record is following you, and no matter in which hospital you arrive, it's like, here is my digital twin. You know everything about me the moment you have that digital twin. So like, in a sense, I see it as the future of healthcare, but I don't know, what do you think about that side? Like, what do you think about?
Yeah, I do think like there's so much value in it, and like one thing I'm curious about is once you have this kind of engine, you can basically work out the counterfactual, which means like if you know your current path or disease trajectory, you can also simulate virtually what happens if I start taking this drug, what happens if I start doing this exercise. Can I stave off dementia? Can I stave off heart disease? The use cases are very wide, and I fully agree. Like the way data is held at the moment in the hands of these monoliths, whether that's healthcare or whether that's Google, Meta, whatever. I don't know, it's very dystopian in my view, and there should be more of a push to actually, take control of your own healthcare records. And like Zeljko said, you own the data, you control the data, and it's basically trying to bring power back to the individuals and the patients and away from big tech.
Okay, so we have the scribes, we have the chatbots, we have the digital twins, we have the computer control, and that's like just the top of the funnel. What does NHS need to do to become like AI enabled? How can we bring all of these into the NHS?
I feel like everyone's probably heard a million variations of this in the past few days, probably. I think on the ground level, I think in the last talk they made a great point, right? Like, even if you have the best tool, the best technology, if the clinicians aren't empowered to use them and educated to use them, it's going to fail. Scribes being a great use case, scribes are useful, but there is a specific way we should be using them. We need to check them for hallucinations. We need to make sure it's doing the right thing. Even those simple, like, digital health hygiene tips, a lot of doctors won't know. For example, if I use an AI scribe, I'll vocalize everything. So I change the way I consult with a patient. If I do a physical examination, in the past I'd just do it quietly, but now I'd actually shout out, my findings and what I'm actually doing. So there's simple things you can do to upskill and to make technology more, like 10 times more effective, right? Like if you started narrating things clearly in a way that AI could understand you and make notes succinctly, that improves everyone's life. There's less admin, the patient feels more heard, they understand more, there's a better hospital record. Yeah.
I do want to mention one really important part on my side here is that I think this is something we have to do. I don't think this is an option because in my side, this is progress. And if we are hindering progress in this case, we are effectively harming patients. I think hospitals and everything else, AI obviously is bringing a lot of benefits in a lot of areas. And I want to have that impact also in hospitals. If someone is telling me now that I can use an AI scribe and I don't have to spend time typing, we should try to do everything to enable that. We should try to make some tests. If the AI passes that test, then it can be deployed in the hospital. Have a way of doing it without that being 17 steps of governance and regulation and everything else, because every single company I spoke with was complaining that I need 3 years to get into the NHS. To me, that makes no sense. It's everyone is saying, oh, health is really difficult, really hard, and we have to be very careful. I agree, but there is 100 other areas where we should be very careful, and we are still doing it. Self-driving cars are becoming almost the daily. They are as dangerous as health. If a self-driving car is driving that car, it should be very safe. In the same sense, to me, is AI scribe transcribing what the doctor is saying.
Yeah, it's definitely safer than self-driving. I mean, we've seen on the news self-driving cars are crashing into people at the moment and actually causing a lot of damage. So it's not great. Yeah, but I agree. The procurement procedure, every trust we approach is we have to start from square one, which is really crazy. There should be a standardized procedure.
Okay, and to finish it up, from your side, are you optimistic? So we have two factions in the AI world, and in general public these days, it is the AI, I don't want to call it doomers, but we are going to die in a couple of years, AI will take over everything, we'll lose our jobs, the Terminator scenario, or the scenario of prosper? Where are you on that scale?
I think there's a great saying, which is I'm pessimistic in theory and optimistic in practice. And I think that's the best way to be. In my head, I think AI is not going to be our savior, but there are some really great positive use cases out there. So, I spend my life and you spend your life trying to work on those use cases and implement them whilst understanding the trade-offs of safety, of compliance, of ethical concerns. I think that's a really fine line to tread. And I think in general there's not enough AI safety researchers out there. There's a statistic, for every 10 AI researchers, there's only one AI safety researcher. And that's insane, considering how much AI is being thrusted and pushed upon us. There needs to be more understanding of the dangers that has in practice. How about you? Are you doomer or gloomer?
No, I'm ultra optimistic. So I'm completely on the side of okay, let's use AI for everything, or AI will be used for everything. But I do have, this is from personal experience. This is not every single, I'm of course coding my whole life, so I'll tell you examples in coding. Every single coder I have seen recently is using AI actively, and every single one you ask will tell you I'm at least 50% more efficient and effective than I was before. Coders are the first to take on new technology in most cases. So if they can do that, why not in all the other areas? I'm sure we can find places where AI can help. And to whoever tells you that AI will take your job, why is every single AI company hiring 100 engineers a day? If the AI will replace all the engineers, then they don't need them. Why are they hiring them? So obviously, I think the case is that an extremely good person with AI becomes even better. And that's why I think like knowledge at this stage or learning how to do things is even more important, because with AI, you can do that even better than without AI. Like it is an amplifier much more than a replacer.
Yeah, no, I think it's good to end on an optimistic note. Maybe we just open it up to questions. Yeah, we've got a couple of minutes. Yeah, any questions? Anyone?
Yeah, Mr. Lally, one of the consultants. This new AI-driven agent is quite fascinating. Now, you mentioned that designing digital twins is a bit challenging. Now, is it easier to follow through cohorts, that is designed according to cohorts, as a group of people, or on individual levels? Which one is going to be easier for you to design?
Sorry,
So for example,
your question
okay, I'm the black man.
You're a bit closer the microphone because we cannot hear you.
Sorry.
Yeah, sorry.
Okay. So what I'm trying to say is it going to be easier for you to design along cohorts or individuals? These digital twins, yes.
Yeah, so you can train it both ways, but digital twins, your question was, are digital twins designed for cohorts or individuals?
Is it easier? Which one is easier? Because you said it's difficult to do it. That's one of the challenges, that it's very difficult to design.
I think you can design it both ways, but at the moment, the individual, there's a direct use case because it's the individual we want to empower to make changes.
Yeah, but it is easier to design cohorts because it allows you really to simulate whatever you want. Like it allows you also, like it is good for example, for clinical trials or similar, because you can take the whole hospital, take all the digital twins, simulate the next 3 years and understand are they a good fit for a clinical trial or not. So like it allows you to cohort people better, basically, in my mind.
Yeah, thank you.
Hi, thank you.
Hi.
Thanks for the talk. I wanted to ask on what are some of the lessons that you've been able to take from the building of AVTs in the NHS right now that you take towards building digital twins, whether it's in healthcare institutions or for consumer space, as well as other future products that might come out, especially like voice agents right now that could be used for, or autonomous voice agents for triaging and other aspects.
Shall I take this one? Yeah. I guess that's a big question, but I think the main learnings I'm seeing is that building ambient voice technology for the NHS. I think I covered a bit about regulation, a bit about funding, but what I'm seeing is that all the risk at the moment is being taken on by the startups, by the digital twin startups, by the ambient, and you can see big tech is supplying the agents almost like electricity. We use the analogy of OpenAI is now like an electricity company. It's supplying intelligence on a tap. And these platform companies that people are building on as well, they're basically supplying the infrastructure. So what I would say is, my main learnings is it's probably better to be a platform company or a big tech company than the startups, because all the risk is offloaded on the startups. But like, I think in a serious way, like, there needs to be some change in the NHS, because what we're seeing is startups are all going to the US, to Australia, to other places to innovate and staying away from here.
And just to add on that, I think my main thing is start small with something useful, and then it's fine. A lot of these companies also start with, we'll change the world in a year. No, you will not. Like, also, if you come to the NHS or to a hospital and you present, we can do everything ever, no one cares for you. Like, start with, oh, we will do these specific tasks that you really need, and we will do it extremely well. We have the data, we have the proof, we have a paper that we have shown that we can do that. Then I think it makes sense, then it's fine.
Oh, hi there, I'm Haji, one of the cardiology registrars. So I just had a question about medical summarisation. So I understand you can appreciate, Josh, when you're in a clinical scenario and you're seeing a patient for the first time, one of the difficulties is trying to figure out everything that's happened until that point, particularly when it comes to acute situations. So where do you think we are in terms of effective clinical summarisation, and what are the barriers to that?
Oh, LLMs are great at summarizing stuff just because of the way they're trained. And everyone's worried about hallucinations, so large language models once in a while can spit out something which doesn't make sense, it's nonsensical, it's not in the training data. It was a big worry when ChatGPT came out, But what we've seen is year on year, the hallucination rates are decreasing. So like for tortoise, we actually published a paper on this. The hallucination rates were about 1%, and that was in 2023, 24. And every year now, it's probably decreased by a factor of 10. But the crazy thing is, now that it's more rare, it's arguably more dangerous, right? Because people stop checking for them, and something can slip through. So that's where the digital hygiene comes in, and clinicians understanding AI.
I mean, I agree with that, but also like you said, it was 1%. Now it's maybe 10, 20 times less than that. So it's like 0.1 or 0.1%, like, sorry, 0.01%. Like, what is the hallucination rate for humans? That's also something I'm seeing constantly, is like we are comparing the AI to an ideal, even though humans might make like 10 times more mistakes. Like, we should compare them to something that is currently there and see, is the AI improving on the current state of the, or what we currently have in the hospital.
Yeah, we did that test. AI outperforms humans in terms of hallucinations, but ethically it's different. No. Ethically it's different.
Okay, that part we can disagree. I don't think it is.
One last question, maybe?
Yeah, just on that last point you mentioned is a really interesting one, because I agree. So the hallucination rates, what is it compared to a human? But the issue surely is also detectability. So if you have a human, they're seeing a very small number of patients, whereas you might have an AI agent across multiple healthcare organizations. And if there is a bug, and detectability with AI sort of software is more difficult, that can very quickly be amplified and multiplied to a much. And then the other issue is, where does the liability lie? And that's a significant issue for the entire industry, surely. Not, sorry, so much of a question, but I'll come back.
No, but I do have a comment on the first part. I prefer a systematic error over a random error. Like, if you are talking about 1,000 humans will all make mistakes, all in a different way. I prefer a systematic error that's always the same, and I can easily find it, over a one that is always a bit different. So
I don't know. Like, no, no, because it depends. If it's systematically against a group, then it's different. Like, if it's a minority group, or if it makes the same mistake, like you've seen for the skin cancer detection stuff, it's noticeably worse for people with dark skin. Like, that's not a systematic error. That's okay.
No. I'm saying it's easier to detect. A systematic error can be fixed easy, but a random error is nearly impossible to fix. But okay.
Yeah. Do we have time for one last one? Guys, can we take a quick selfie just whilst we're here for socials? Okay. Smile, say cheese. Last question.
Yeah. Thanks very much for a great talk. I'm an NHS doctor and founder of a company called Assuric, and we help AI companies with compliance and deployment in the NHS. So you mentioned a few kind of challenges and barriers to AI deployment in healthcare, especially compared to some other industries like coders you mentioned. Some of the things you mentioned around kind of like regulation, procurement, adoption. You mentioned the kind of EPR not enabling integration and challenges there. I'll just be interested to hear kind of what do you think is the main barrier that if we could solve would kind of unlock a lot of AI deployment, and do you have some sort of potential solution that could enable faster AI adoption and deployment in healthcare?
I think there's not one main thing, but I think one thing I was super surprised about is the regulation side. I recently went to like a roundtable for regulators to decide what happens with working with the MHRA. I was shocked. Do you know how many people work for the AI branch of the MHRA regulation? 1.5 people. 1.5 for the entire like UK and EU. It's insane. So like, no wonder the regulation lags behind by 1 or 2 years. And no wonder no one can, scribes have been around for 3-4 years, and it was only this year where the NHS England, made a clear statement of intent of what to procure and like what the requirements are. That's really stifling innovation, in my opinion. It takes way too long for everyone to sing on the same hymn sheets. So probably for the MHRA side, there needs to be more funding for them. I don't know if you had anything to add.
I mean, it is part of that, but really to me it is like make one framework and make it standardized so that if I pass in one hospital, it also applies to the other 50. And also just like make it somehow not last years, like make it somehow, okay, we have this framework, it has to take at most 3 months. If you come to that hospital, you apply with your use case. If you pass that, you are ready. If you don't pass it, you are not ready, you try again. But like make it standardized, make it a bit more. Then you come to the hospital like, yeah, we have no idea, but we also have no one that works on this, but also we don't really care. What are you going to do there? Like you have to basically almost push the hospital to implement something as much as possible, as much as you can.
Yeah, and I think collaboration between companies and the hospitals, like, I mean, you can see Palantir's model. Palantir is not a great company, in my opinion, at the moment, but financially they're doing great. But they have these forward deploy engineers where the engineers from that company basically come to the hospital to implement the tech with you, and they sit with the users, sit with the IT to basically upskill them so they can continue to roll out and get the most out of these products. So yeah, I think that's something that we should see happening in the near future as well. A lot of tech companies are talking about forward deploy engineers, but should we?
We should wrap. Okay. Awesome. Thank you everyone for attending. You can find us twice a month on the Dev and Doc channel. And once again, thank you and we hope to see you soon.
Thank you.